That's a pleasure. Thanks, Julia. It's a sunny evening here, Saturday evening in Sydney, Australia. For those of you who are joining from other parts of the world at all sorts of times, kudos to you for making it. Just share my screen and pull up my slides, and then let's get going. So I hope you can see them now. It's a real pleasure and a privilege to have this opportunity to talk to you. And just closing the window there with a bit of outside sound. I will be speaking about childhood encephalitis, but I'm going to focus in particularly on some of our work here in Sydney, partly because Carol Glaser, who's a keynote speaker later in the day or the evening or the night, wherever you are, is going to give a really big picture view over a longer horizon. So we all know this, that's why we're here. Encephalitis is a complex neurological syndrome caused by inflammation of the brain. But I really do like this quote from Sarah Long. This is the textbook she edited in Pediatric Infectious Disease. It's a challenging condition because of its severity, because of the many causes, because of the lack of treatment options and lack of identifiable etiology in most cases. And this landscape is really what drives forward many of us in terms of trying to make improvements for patients and families with encephalitis. And I'm going to start with two stories because these are influential for me. When I was 12, my family was holidaying on the far north coast of New South Wales, a place called Ballina. And I remember my sister had woken up feeling a little bit unwell that morning, hadn't come to the beach with us, as we would normally do in the morning. And then we were having a sort of quiet time, I guess, in the early afternoon, my parents settling the kids down. And my sister, who'd, again, just been feeling a little bit off, started fitting. And she went into status epilepticus and needed to be evacuated to the closest referral hospital and have her seizures controlled, and then transferred back down to Sydney. And like many families with children with encephalitis, she had several weeks in hospital and then many years of ongoing follow-up without a cause identified for her illness. I'm glad to say she's doing very well now as a young adult, mother of 3 children. But that's a common story. This second story is when I started my doctoral studies in childhood encephalitis. This was one of the first children it was included in our cohort studies. This was a young boy, 3 years old, again, woke up feeling a little bit unwell. His mother gave him some paracetamol, as many parents do, put him on the couch to watch some television, went out to put the clothes on the washing line, came back in half an hour later to find him semi-comatose. He was taken by ambulance to hospital. Within 12 hours, he was in intensive care with a brain scan showing this kind of swelling deep in his brain, and within 24 hours, he was declared brain dead. So absolutely devastating illness, and he'd had influenza. So this brings me to summarising again for us all. Why is encephalitis important? Well, the first story illustrates that still for many young people, children, adults, the cause of their illness still eludes us. The second, and I guess in many ways most important reason why it's important, is the consequences. It causes death. It also causes significant brain injury and short-term neurodisability. It also causes long-term cognitive and behavioural problems. And there's also a third reason why encephalitis is important, less important than that second reason, but still significant, which is it's a canary in a coal mine. It's a marker syndrome for emerging and serious infectious diseases. And I hope today to illustrate from our work in Australia these 3 important factors. Now, people tell me not to bury the lead in talks, so I'm going to give you a bit of a headline list of numbers from our work that I think are relevant to encephalitis. Mainly, I must say, in high income or resource advantaged locations, less relevant to maybe low and middle income countries, but still it captures the picture. So the first thing I'd like to highlight is, even though encephalitis with unknown cause is still a big issue, in fact, in childhood encephalitis in Australia, we can identify a cause in about 80%. And of 70%, there are only 8 causes that cause the vast majority of disease. But it is still acutely very severe. 1 in 2 children go to intensive care, and unfortunately and devastatingly, 1 in 20 children won't survive. In terms of the more long-term, 1 in 4 children will leave hospital with evident neurodisability. And then even more strikingly, over the medium and the long term, that 1 in 4 actually becomes 1 in 2 in terms of some kind of long-term impact from their illness. And yet still, amongst those 8 leading causes, as I like to call them, for half of them, we have no specific treatment. So there is a huge amount of work that still needs to be done. Many of you will be familiar with this clinical case definition for acute encephalitis syndrome from Arun Venkatesan. I think I've misspelled his name there. I probably apologise to Arun and others. And what this, I think, highlights, and what I want to highlight, is this is complex. It's complex to diagnose and manage, and no 2 cases are exactly the same. And that's why we have to have these major and minor criteria with variable findings, and they mix and match. But there are patterns, and again, I hope that we'll see some of the patterns come out in today's talk. Another concept I want to bring to your attention at the very start is the idea of encephalitis versus encephalopathy. And this is really an oldie, but a goodie. This is a review article from Nick Davies from London from 2006, where he very nicely brings out the difference between 2 particular things: acute infectious encephalitis, where the bug infects the brain and there's direct inflammation and infection damage to the brain. In contrast, this acute encephalopathy in children, where the bug less often goes to the brain and where the injury to the brain is mediated in a slightly different way to classic inflammation. But both of these will be identified using the previous case definitions or clinical definitions that I just showed to you. So that brings me to our work here in Australia. This is our study, the Australian Childhood Encephalitis Study, which is ongoing, I must say. And our study works based on an active surveillance network called the Paediatric Acute Enhanced Disease Surveillance Network, where we have a team of surveillance nurses in hospitals around Australia who try to identify children who may have encephalitis, or we call it suspected encephalitis. And those children and their families are then invited to join, or without invitation, their clinical data can be collected in a de-identified way. We take all of that data and we review it with neurologists and infectious disease physicians and microbiologists to categorise those cases. We've also been fortunate, if those families agree, to be able to access biospecimens from those children from the laboratory, and then we have and are continuing to arrange follow-up studies over the medium and the long term. In terms of that panel that reviews all the data from cases, this is essentially, in a simplistic way, what we do. We take our cases of suspected encephalitis, a proportion of them, we decide they don't meet that kind of complex clinical case definition that I just described, and they become inelegantly not encephalitis, but they still are important to us, and we retain their information and try to understand their specific diagnoses. Amongst those who get called encephalitis, we separate them into the 3 broad groups, as many people, researchers around the world do, of infectious, immune-mediated, and those with an unknown cause. And where they're infectious, we do our very best to understand the cause and express just how well we understand the cause. And then we categorise the immune-mediated into major groups. Now, obviously, you don't need to read everything in the slide, but this just gives you a sense of the overall numbers. To the end of 2016, and we've published our data in Clinical Infectious Diseases last year. To the end of 2016, we'd had over 500 children with suspected encephalitis identified. Now it's over 1,000 because we're continuing to identify children. Of those, it's about a half that we think meet that more rigorous definition of having confirmed encephalitis. Amongst them, 50 to 60% will have infectious causes, 20 to 25% immune-mediated causes, and about 20% unknown causes. And this is a headline table from the papers that you can go and look up if you are interested to follow it up, or you could contact me directly if you'd like a copy and you can't access a copy. But what I want to highlight here is there's 6 of infectious causes and 2 immune-mediated causes that account for the vast majority of our known causes of encephalitis in children. Amongst the infectious, the 2 picoRNA viruses, the enteroviruses and parechovirus, the severe end of bacterial meningitis that we call bacterial meningoencephalitis, influenza, herpes simplex virus, and somewhat controversially, but interesting in its own right, the unusual bacteria Mycoplasma pneumoniae. And amongst the immune-mediated causes, there's this syndrome, acute disseminated encephalomyelitis, and the antibody-mediated cause to which many of the audience will be familiar now, the anti-NMDAR or N-methyl D-aspartate receptor encephalitis. And there's a speaker later in today's program who'll be addressing that directly. Now, one of the other things that's been really interesting is amongst the infectious causes amongst children, they've come in waves. And so just to illustrate that, early on when we started doing our study, we had an outbreak of enterovirus A71. Again, members of the audience will be aware of that virus. Subsequently, later in 2013, and then in 2 subsequent epidemics across our study, we've had a virus called parechovirus type 3. Every year we see children with our seasonal influenza epidemics with influenza as a major cause. And in 2015, in an epidemic year of Mycoplasma pneumoniae, we saw this clustering of young people with Mycoplasma pneumoniae encephalitis. And one of the key things that has come out of our work, and I think important to highlight today, is that even within children under the age of 16, your age is a key determinant of what are the major causes for you. So this just gives you the spectrum of ages. The orange is infectious, the green unknown, and the yellow colour immune mediated. And you can see as you get younger, the infectious causes predominate. As you get older, the immune mediated causes make up more. And along the bottom there, you just get this breakup where parechovirus and bacterial causes in the very young children, then in the infants, enterovirus and herpes simplex and influenza, then in the older children, mycoplasma and the immune-mediated causes. And this is a severe disease. As I highlighted at the beginning, half of these children go to intensive care. 1 in 20 children, very sadly, won't survive their illness, and a quarter have neurodisability at discharge. And when we look at those factors in the acute illness associated with more severe outcome, I just want to pick up that amongst the infectious causes, it's influenza and herpes simplex virus that stand out. And that's interesting conceptually as well. And I want to walk you through this because herpes simplex virus can be thought of as the archetype in many ways of infectious encephalitis. This is the classic situation where the virus gets into the brain, it infects the neurons, it damages the neurons, and causes an immune response in the brain, an inflammatory response in the brain that also has a hemorrhagic factor. And testing for the virus in the cerebrospinal fluid is highly sensitive and specific. In contrast to that, influenza is a very different cause because it rarely actually infects the brain itself. And so we consider it to be a cause of indirect pathogenesis. And so instead of being described as an encephalitis. It's probably more accurately described as an infection-associated encephalopathy. And there's many and varied syndromes of this. And I can't go through this because of time, but some of these acronyms will be familiar to people, maybe particularly the acute necrotizing encephalopathy. That was the young boy I described at the very start of the talk. A very severe syndrome with, 1 in 4 children won't survive that illness, all the way through to much more mild illness, the mild encephalopathy with reversible splenial lesion, where the recovery is usually quite quick and complete in the vast majority of cases. Now that stands in contrast to the single most common cause of childhood encephalitis as we've observed it in Australia, which is ADEM, or acute disseminated encephalomyelitis. And we and others in the UK have seen an increasing incidence over 10 or 20 years of this as a cause. And this is classically thought to be a post-infectious phenomenon. And we showed that in a reasonable proportion of the cases that we identified, we could describe an infectious association, and I've listed them for you there. And so that leads me to conceptually one of the main things I'd like to discuss with you today, which is models of childhood encephalitis that I think are important for us moving forward in terms of directing our efforts towards better treatment or more personalised and focused treatment. So here we have, the brain and spinal cord bathed in cerebrospinal fluid. And in some children, the infection, and here I've just got a schematic of a virus, but it can be other causes, actually gets into the cerebrospinal fluid and into the brain, and we end up with damage to the brain in response, partly from the virus, partly from the inflammatory response. And so that's so-called infectious encephalitis. And I've said HSV is an archetype for that. Alternatively, in some children, you have an infection somewhere else in the body, and you get an inflammatory response or response from the body. And even though that infection doesn't get into the brain or the spinal cord, somehow it triggers an inflammatory response in that space that goes on to cause damage. And that's infection-associated encephalopathy. And I've suggested to you that influenza is the archetype of this. And then finally, you can imagine you have the brain, you have an infection somewhere in the body, and your immune system responds to that in a specific way. And then that immune system cross-reacts or misreacts with the brain and the spinal cord, causing damage. And this in childhood in particular, in adults, it may be tumours that are the major drivers of this kind of immune reaction. But in children, it appears to be infection. And so I like to suggest that we have a triad of infections and the way in which they cause brain injury through encephalitic means, and they're overlapping. We have the infectious encephalitis as an archetype, we've got the encephalopathies, and then we've got the immune-mediated causes. And these three are distinct but overlapping. And to illustrate that in particular, many of you now know that herpes simplex virus is itself a trigger of the anti-N-methyl D-aspartate receptor encephalitis. Here's a case of a child that is included in our studies, a 13-month-old girl who got herpes simplex encephalitis. And then on treatment, she was responding well. And then 3 weeks in, she became more unwell, abnormal movements, and she was found to have anti-NMDAR. And so here we have post-infectious antibody-mediated or immune-mediated encephalitis. And so to summarise here, I think I've shown you that childhood encephalitis is caused by a particular spectrum of pathogens, of which 8 causes account for the majority. Where there are infectious causes, particularly, they tend to come in waves or in epidemics. That age is a key determinant of the causes. And I also think I've illustrated to you that brain injury does result, yes, from prototypical or archetypal encephalitis, But brain injury also results from the infection-associated encephalopathies, and equally bad brain injuries and equally bad outcomes. So they shouldn't be considered as phenomena that are apart, but together. And I've shown you that the short-term outcome is influenced by cause and how severe the disease is up front. So let me turn briefly to unknown encephalitis, because 1 in 5 of the children that we have studied do not have a cause identified. Now that's lower than what has been historically described, but it's still high and still a major frustration for both clinicians and for children and their families. Now, we were hoping that we'd be able to identify factors, clinical factors or exposure factors that gave us clues, but in fact, there were no clinical features or exposure histories that were overrepresented in our unknown group. And sadly, despite quite a lot of advocacy and guidelines, we still have this phenomenon of incomplete testing in children with encephalitis that remains an ongoing need. Now, we and others are continuing to pursue unknown encephalitis through technologies like metagenomics. I don't have time to spend on this particularly, but to say that obviously the University of California, San Francisco group, Michael Wilson and others around America have been real leaders in this space, but we are doing this work with some of our patients as well. Equally, there are now multiplexed serological technologies, and there's been movement in this space in the last couple of years to increase our capacity to address causes amongst that unknown fraction. And this is a very interesting area of conversation, how these technologies will interface and interact to improve our understanding in the years to come. Now, what about management? I said up front that it's still half of our cases amongst these leading causes don't have a really specific treatment. And I've just chosen to highlight 3 areas today. There's the ongoing question of intravenous immunoglobulin for infectious encephalitis. And it's unfortunate that the randomized control trial, the Ignite trial that was planned and funded in the UK, the funding for that trial was pulled in towards the end of 2018 and 19. And so that remains an ongoing question. What about corticosteroids for herpes simplex virus encephalitis in addition to antivirals? Well, there's some evidence, but again, we still don't quite know. But I'm pleased to say that the United Kingdom randomized control trial, the DEX-ENCEPH trial, has, I think their website said, recruited 78 of a target 90. So hopefully, at least amongst adults, we'll have some high quality evidence in the near future. But again, children, we don't have that data for children yet. And what about antivirals for enterovirus or parechovirus? Well, that is an open space, and we still lack antivirals for these leading causes in young children. And so the management of childhood encephalitis, as well as the etiological investigations, still has a long way to go in terms of optimization. And there's still this ongoing challenge of unknown encephalitis. We still lack directed treatments for many of the causes. And that drives a lot of us forward around the world to continue to improve what we're doing. And I think I've illustrated to you that we have to think about infections and the immune system as 2 sides of the same coin increasingly, and look at how we can use treatments that are pairing up together in targeting those 2 elements of the disease in order to improve outcomes. So childhood encephalitis is caused by a different spectrum of pathogens to adults. The main causes are epidemic prone, or they could occur in outbreaks. There's a variety of actual pathologies or processes going on in the brain depending on the cause. And we have many, many ongoing challenges. And days like this, both to gather together researchers and clinicians and patients and families, and to galvanize our sense of continuing to focus on this challenge and work together are a great thing. And so, look, clearly there's many, many people who've been involved in Australia in the work we've done over the last 7 or 8 years. In particular, kudos to Professor Cheryl Jones, who was my PhD supervisor and now the Dean of Sydney Medical School, and Professor Russell Dale as well, who will be known to some of you for his fantastic work on immune-mediated encephalitis in children. And I might just leave you with this poem from Emily Dickinson, which I won't try to interpret for you, but I'll read to you. But it's a great kind of reminder of just how important the brain is and what we're dealing with when we're dealing with brain illnesses like encephalitis. The brain is wider than the sky, for put them side by side, and one the other will contain, with ease and you beside. The brain is deeper than the sea, for hold them blue to blue. The one the other will absorb as sponges, buckets do. The brain is just the weight of God, for heft them pound for pound, and they will differ, if they do, as syllable from sound. So thank you very much. I really do appreciate this opportunity. I appreciate all those who've joined, wherever you are in the world, and I hope the rest of the day is informative and challenging and interesting, and it'll be a pleasure for those who are in Australia who've joined. If you've not met me before or been able to make contact, please contact me. You can look me up on the University of Sydney and send me an email, and really looking forward over the coming years to continue to galvanise those working in this area in Australia and continue to connect internationally to do our very best to improve treatments and outcomes for children. Thank you very much.
Thank you so much, Dr. Britton. That was a fascinating insight into your work. And I loved the poem. We always say that we feel that the brain is the last unexplored organ. So thank you to you and your colleagues for being pioneers in trying to understand encephalitis in children. We've got some brilliant questions as well from the audience. I hope you don't mind staying to answer some. And thank you so much again for being so kind as to offer for people to just drop you a line if they have any burning questions. That's really kind of you. So thank you.
Brilliant.
Our first question is, in your experience, are you seeing more cases with a diagnosis of A&E as it's slowly becoming more recognised?
Look, I'm not sure about that. I think it is increasingly recognised. Certainly when we started doing our work in Australia, it was seen as an extraordinarily rare thing. But since we've been looking closely and really categorising the cases, we absolutely see a small number of cases every year in children. And this is one of the most devastating forms of encephalitic illness that we see. And it really hadn't been described with huge frequency before 2015 outside of East Asia. But then there was work in the UK, as you will know, Julia, that really on flu that brought it to light. And then we've done a similar piece of work in Australia. Now, influenza is not the only cause. I don't want to suggest that, but it's one that certainly captures its frequency on an annual basis and then points to its severity. And we really have to start to move towards more protocolized treatments to really define how to prevent some of the severe outcomes that we see from this.
Yeah, no, that's so true. And it's referred to as both an encephalitis and an encephalopathy. Which would you say is the correct term?
Yeah, that's a really great question. I think technically speaking, it's an encephalopathy, but because the clinical definition of acute encephalitis syndrome captures it, it gets called encephalitis. We've, again, inelegantly tried to represent that in some of our publications by calling it encephalitis/encephalopathy. I acknowledge that's kind of a little bit cumbersome, but I think technically it's an encephalopathy. But I think occasionally when that word gets used, it's almost like the disease gets demoted.
Yeah.
And we're trying to pull it into people's minds and say, actually, encephalopathy of some causes is just as severe as classical encephalitis. and let's not pull them apart. Let's see them as together, but same but different, is how I would phrase it. And so it's incredibly important, though technically speaking, it's an encephalopathy.
Thank you. Another question, great question, I think. If influenza is a cause of childhood encephalitis, should all children have a flu jab?
Yeah, and this has been quite a remarkable movement in Australia. We essentially had nationally funded influenza vaccine for children with medical comorbidities. And then over about the last 5 or 6 years, partly through influenza surveillance, just focusing on influenza and its respiratory morbidity, but really quite importantly, bringing in the neurological morbidity, those two things together convinced our government in Australia to fund universal influenza vaccine for children under 5. And that's only just come in Australia. I know it occurs in other parts of the world, but that's been a major, major change in Australia. We haven't been doing it for long enough to really see if that's going to function as the way we'd like it to do, which is to prevent some of these severe illnesses. But we strongly recommend annual influenza vaccine for children under 5, and that's where it's funded in Australia. But of course, I'm an enthusiast of vaccination and would recommend it to all children and young people. And of course, I'm a healthcare worker and I get my jab every year.
So true, especially now, never been more important. Another great question. What are the top tips for parents of children with encephalitis? What can they do to help recovery? Are there supplements? Are there particular foods? Are there top tips for exercise or therapy to help children recover, have the best recovery possible?
It is a wonderful question. And you know what? I feel inadequate to answer it. I wish I could say to you, we've defined the best pathways to recovery, but we haven't. We are continuing to work in that direction. What we really recommend in Australia, and I think it's starting to change practice, is that all children with encephalitis, once they're discharged, they get formally assessed by a rehabilitation service, and that assessment can be used to guide, individualised recovery plans. Now, we haven't got that up to 100% yet, but we are absolutely pushing it. In our hospital, we are seeing many, many more children get a formal assessment of the impact, and then that's really informing things like school return, individualised support plans for children going back to school, as well as better communication with families about what to expect over what time period. Now, I know the UK Encephalitis Society has been an extraordinary advocate for this in the UK, and we're certainly taking those learnings and the resources and using them shamelessly, but we're not there yet, and I wish I could be much more helpful in terms of specifics for the person who's asked the question, but in time, hopefully we'll be able to tease out some of those specific needs and specific responses.
Thank you. That's really helpful. And you carry on using our assets as widely as you want. Another question from the audience: is encephalitis a notifiable disease in Australia?
No, it's not notifiable, but we're getting some traction on that as well. In fact, when we started our research, it was all funded, it was cobbled together through multiple funding sources. And one of the things that has changed is for children, not yet for adults, but for children, our surveillance is now Commonwealth funded in Australia. And so that's been the case now just for the last 18 months. But that was a really significant thing now that there's structural funding from the government to continue to monitor this syndrome. We hope that over time we'll get traction into the adult space as well for that, because I think when it's watched, and it's watched by government and health departments, that's when the burden is recognised and when the responses will begin to become more embedded.
That makes perfect sense. Couple more. Can a patient with autoimmune encephalitis receive an influenza vaccine or any other vaccine, or does it need a conversation with a physician?
Yeah, I think I would defer to your individual doctor with respect to that question. I think generally speaking, in most circumstances, vaccines will still be very safe. But I wouldn't want to be giving you that direct advice, I think. But talk to your doctor. Doctors love to talk about vaccines.
As you know, this conference has been organised by an alliance of non-profits. What can we as non-profits do to support you in your work with children affected by encephalitis?
Yeah. Look, I've been thinking a lot about that recently, actually, because even though there's many people in Australia who interact with some of the organisations who've, organised today, we actually have not yet developed that kind of presence in Australia itself yet. And I think there's huge benefits to the patient and family-led and not-for-profit sector. There's benefits in terms of just mutual understanding and support. There's benefits clearly in terms of advocacy to things like research funders and governments. And then there's the movement itself generating things like support and funds. Now, over time, that it may be of lesser or more importance, depending on the season. But all of those elements mean that really advocacy, mutual support, funding, and still I think there is a real place for patients to say, hold the phone, you researchers and clinicians are focused on certain things, but they aren't the things that are most important for us. And we still need to receive those messages consistently. And all of those things really point to the importance of the sector, the importance of the organisations, and the importance of days like today and meetings like this.
Thank you, that's so helpful. This is the last question we've got time for. Are all patients tested for autoantibodies when, and if they are, which ones? Yeah,
so the answer is, I can't say they all are, but the proportion of patients in Australia who are has dramatically risen amongst children since we started our work. We, in our Australian guidelines, and they're up for review, we published them in 2015, we recommend universal testing for NMDAR if an alternative cause is not identified in the first 48, 72 hours. Okay, so that puts aside the infectious testing that often comes back in that window and can identify many. But if you don't, we are advocating for NMDAR to be tested for because it makes up about 15% now of childhood encephalitis. Beyond that, it's very hard to recommend for universal testing because actually amongst the other antibodies, they make up a much smaller proportion and the variance is different. Now, some places have panels and where you've got a panel, that's a great thing. You know, many of the major hospitals in the US and some in the UK will have fixed panels and I think that's laudable. But I don't think we're at the place yet that beyond NMDAR as a major cause that we need universal testing. I think it's much better to have that more stratified and focused approach from clinicians who are familiar with these disorders.
That makes perfect sense. So thank you so much. We cannot thank you enough for sharing your expertise and your passion today, and we wish you every success in the future, and we hope that we're never strangers with you and your colleagues in Australia, and anything we can do to help as non-profits, then obviously holler. So thank you so much for your time. We've really enjoyed hearing from you today.
Wonderful. Thank you so much.
Thank you.